All right, hello everyone. I think you can hear me okay, it sounds like. This is a big talk to manage in 40 minutes, but I'll try my best. In addition, I'm gonna hopefully work this remote. I haven't done that yet, but we'll go for it. And really to try to improve antimicrobial stewardship by limiting inaccurate antibiotic use because of inappropriate antibiotic allergy labeling. I have no disclosures, and here are your objectives, just so you have them for learning. And first, to talk about this, we really have to define a couple terms because we need to really be able to identify the difference between an adverse drug reaction and a drug hypersensitivity. An adverse drug reaction, by definition, coined by the WHO clear back in the 70s, is a response to a medicine which is noxious and unintended and which occurs at doses normally used in man. And this is kind of an umbrella term. And to clarify, you can divide these down into two main groups. Type A, which comprises 80% of adverse drug reactions, and Type B, which is 15 to 20%. Type A are predictable, dose-dependent. An example of this would be hepatotoxicity with an acetaminophen overdose. Type B, this is where we're going to focus our talk on today. These are unpredictable, dose-independent, and drug allergy is part of this. And it does include other things, including pseudo-allergic reactions, which we will touch base on today, as well as hypersensitivity reactions, which equals drug allergy. So drug allergy, by definition, compared to an adverse drug reaction, is an immunological mediated drug hypersensitivity reaction, meaning the immune system is doing something to that drug or with that drug in the system that then is leading to symptoms. Classically, we think of an immediate hypersensitivity reaction, which is IgE mediated. That's the picture here, where you can imagine that little orange rectangle is a penicillin. Someone had a previous history of penicillin use, became sensitized. They formed IgE antibodies to that penicillin. Those IgE antibodies sit on a mast cell, and the next time you give penicillin, those cross-relink and the mast cell activates, and you give everything that we think about with immediate allergic reaction, all the way to possible anaphylaxis. And the mediators that are released with this include histamine and tryptase, and therefore, if you are concerned about immediate allergic reaction, you can actually check a tryptase about 90 minutes after that reaction for the ideal timing. Histamine can be checked, but it has to be done within 30 minutes, so from a practicality standpoint, you just can't do it. So, in our field, we kind of feel like everything is an allergy. A patient could come in and say, my doc, my pinky hurts. It must be this new medicine that you just gave me. And there's a study that patients were actually coming into physicians' clinics in one of the Asian countries, I can't remember which one, with this deformity, and it was actually related to frequent cell phone use and how we hold it. So, not everything is an allergy, and I try to make light of that. And we do need to listen to our patients, but also need to be good stewards and really try to identify what is a true allergy. This study was published in 2017 from the people at Mass General, and they have a lot of allergists on their staff. They have 40 allergists. To give you an idea, we have 4 at Nebraska Medicine. But as you can see, only 0.2% of the allergies listed in the EMR were produced or entered by the allergists, and over 30% were unknown. And they were looking at, in the study, that allergies do accumulate over time. And this was studied from 2005 to 2012, with that green light showing the allergy list get bigger and bigger in patients' charts. So then it really requires us to be detectives, all right? And why is that? Well, because of the allergy accumulation, the allergy lists get long and inaccurate, and I feel like every allergy that's added, the more inaccurate the recording becomes. The education and knowledge of an adverse drug reaction versus a drug allergy, poor documentation in the EMR. We do want to list something as a side effect. If someone takes an antibiotic and they have horrific GI symptoms, you want to be able to document that, so maybe you don't use that one, but there's nothing in the EMR that makes it easy to be like, okay, this is a side effect, use it if you absolutely have to, but if you have an adequate alternative, maybe don't use it because this patient literally couldn't go to work because diarrhea was so bad. Drug allergy testing is available, but you have to have specialists to do it. It is generally not validated. We'll talk about when it is validated. It's time consuming and requires a lot of coordination care, including our wonderful pharmacists that we have in our audience today. And we can challenge and desensitize patients, but this requires, once again, specialists that know what they're doing and emergency services available. So what are some risk factors for drug hypersensitivity? Well, the biggest thing I want you to know is having an allergic history does not increase your risk. Unlike any other allergic diseases I treat, allergies do not increase your risk. The other thing I want you to think about is how the drug is given. Think of a typical cystic fibrosis patient who's receiving the same antibiotic via IV form in high doses, start, stop, when they come in for their CF tune-ups. Those patients develop true IgE-mediated allergy to their antibiotics. It's because how their immune system is seeing the drug. There are some concurrent illnesses that can increase your risk, including HIV with sulfa and EBV with your amoxicillin. So unfortunately, to do this, we are going to have to get into some immunology, and I apologize for that, but I do like immunology. And if you can go back to your training of Gell and Coombs, that is looking at how the immune system is reacting. Type 1 is our immediate that we'll talk about with anaphylaxis. Type 2 is antibody directed. So that's direct cell killing. So this is like your interstitial nephritis, your anemias, things like that. Type 3 is immune complex, that's serum sickness. And type 4 has 4 categories, and we will go into those. Those are your delayed hypersensitivities. Most drugs can cause at least 1, if not 2, but some drugs can cause all 4, including penicillin. So immediate type 1 hypersensitivity, this is IgE mediated. We already talked about this. This is what leads to anaphylaxis. Usually the symptoms occur less than 2 hours after exposure. They're reproducible, meaning you'll have symptoms no matter when you get it. It can worsen with repeat exposures. Skin testing, fortunately, is usually helpful in these situations. We can desensitize if we need. And the top 2 classes of antibiotics to do this are beta-lactams and quinolones. So for some clinical information, and we know this, we all know what anaphylaxis looks like, but fortunately for us, 90% of patients have cutaneous findings, because if someone comes in hypotensive shock, you need to rule out other things, including cardiac. But most of the time they have cutaneous findings, including itching, redness of the palms, rashes on the face, classic hives, and that fun angioedema that makes you look like you got too many lip fillers by your plastic surgeon. So urticaria, though, does not always mean IgE. So this is a picture of urticaria, and it is associated with IgE, but that rash will happen within an hour of getting the drug. But it can be seen in pseudoallergic reactions. So the classic of this would be red man syndrome with vancomycin. They will get urticaria. It is not IgE mediated. We'll discuss that a little bit more. And in delayed reactions, so some delayed type hypersensitivities that honestly we can treat through if we need to will have urticaria, especially if there's a viral infection known there. It can also be seen with serum sickness, which we obviously need to be able to diagnose, and in bad diseases that we'll talk a little bit, or bad reactions that we'll talk about a little bit more, including DRESS syndrome. So what can we do for immediate hypersensitivity reactions? Well, I can actually skin test, and the other allergists at UNMC can as well. Allergists in the community can skin test. And when can we skin test? For type 1 reactions, possible type 1 reactions to confirm that they were not. Unknown, so a vague history. And really we're trying to say, are you going to have anaphylaxis if we give this drug to you, or are you unlikely not? Because that's what we really care about, because no one wants to harm a patient. And occasionally we can do this for delayed reactions with delayed reads. What does that mean? I do the same process in my clinic, but then I have them come back and read their skin test at 48 hours and 96 hours. Skin testing for drugs is unlike environmental and food allergy testing. It is 2 steps. First is prick, just like the rest of our allergy testing, but the second is intradermal, which is exactly like your PPD testing for TB. So drug allergy skin test procedure is not perfect, unfortunately. Biggest reason is the only drug that is validated for is penicillin, and that's because that's the only one that we truly know what the antigens are with penicillin. We will talk about what that means in a couple slides. However, I can skin test to most antibiotics. We have non-irritating concentrations in the literature, meaning that the drug concentration is high enough that we can elicit an IgE-mediated response, which is an urticarial rash at the site of the injection, but not a false response, meaning it's just a direct irritation. There are some drugs that we cannot skin test, sulfa being one of them, and vancomycin, because they will directly stimulate the mast cells and they will be positive. I've actually skin test myself just to see the sulfa. I can take it fine, but my skin test is positive. And then hypersensitivity reactions that we should not assess with this include the bad boys severe cutaneous adverse reactions, also known as scars. We will talk about those, and some other things, including things like hemolytic anemia, because this is just looking at IgE-mediated reactions. So management, what if you have someone that has a clear history of an IgE-mediated reaction really close to the time of you needing an antibiotic, or maybe you don't know but you really need the antibiotic, or maybe they even have a positive skin test? Well, depending on what the clinical history is, we can do a drug challenge or a drug desensitization. Drug challenges do exist without allergists. We have protocols in place at our hospital, and I will look at those also in the next couple slides. But this is for patients who have had a negative skin test or an unavailable skin test, and they're at low risk of reacting to you. So an example of that would be a history of beta-lactam allergy. You need another beta-lactam antibiotic in a penicillin labeled allergic patient, or they really didn't have very bad symptoms, or it was a long time ago, or a vague history. We use these challenges to prove that the patient is not allergic. It does not modify the immune response, and generally is 2 or 3 steps, and those numbers there are based on the therapeutic dose, like 1/100th, 1/10th, and full dose, classically 30 minutes apart. And if they tolerate it, you can document that in the EMR, and you can give them the next dose in typical fashion, whatever that dose is. Compared to a drug desensitization, which is where someone likely has an IgE-mediated reaction or an infusion reaction, and it's severe and recent, and this literally modifies the immune system by inducing temporary tolerance. They have to be done in the ICU or in infusion centers via a therapy plan and protocol. And we start with a very baby dose, and basically over a set amount of doses increase you up to the therapeutic dose, and basically slowly release the mast cells so that you don't get anaphylaxis. Many protocols are in place for certain antibiotics. So what about other drug hypersensitivity reactions other than IgE-mediated? So we'll talk a little bit about type 3, which is serum sickness, and we'll talk briefly about type 4, A, B, C, and D, really for you guys to recognize the big bad boys that we can't do much with, and don't accidentally give your patients those drugs. Serum sickness, this is type 3, immune complex. They have fever, rash with joint pain. This is the kid that won't walk because their knees hurt so bad. And they do not have mucosal involvement. That differentiates it from other severe cutaneous adverse reactions. And obviously you have to remove the drug, and occasionally they will need steroids. An appropriate and accurate recording of these reactions needs to be done. Classically, we recommend avoiding the class, but probably this is drug specific. It's just hard to test and validate. And then there's these severe cutaneous adverse reactions that I briefly mentioned through the last couple slides. These include acute generalized eczematous pustulosis, long name from now will be AGEP. Stevens-Johnson TEN, most of you know. Drug reaction with eosinophilia and systemic symptoms will now be called DRUS for the length of the talk and the length of the name. When I was in residency, I didn't know what this was. Now people at UNMC see this frequently, I would say. And in general, we avoid the entire class because we don't want to have patients go through this again. To compare them, AGEP is a type 4D, so it's neutrophil mediated. Classically has this rash with a lot of fine pustules in the integumentous areas. They get fever and neutrophilia 3 to 4 days after starting beta-lactam antibiotics. So you can imagine what happens. That patient gets more antibiotics and they're reacting to their drug. They're not having another infection. Stevens-Johnson TEN, we know this. It's T-cell mediated 4C. It's mucosal involvement, bolus lesions, target lesions that spare the scalp, palms, and soles. They do have a prodromal phase a few days before, and they have a normal eosinophil count. Compared to DRESS, which is eosinophilia, it's actually a reactivation of herpes viruses, classically HHV6, but 8 and EBV have been reported. They have a fever, but it doesn't develop until 2 to 8 weeks and can actually worsen after the drug is stopped, so figuring out which drug did this can be difficult. And it leads to systemic symptoms, including lymphadenopathy and classically hepatitis. It does have a 10% mortality. These patients need steroids, and more steroids with a very long taper, and they need allergy immunology consultation. Examples. So this looks like a really bad rash, right? Like none of us would want to continue to give a drug to a patient with this rash, and it's symptomatic, it's super itchy. This is just your classic type 4C drug exanthem. It's fine. If they need that drug, as long as you're watching their labs, their cell counts, their liver function, their LFTs, their kidney function, they're not having a fever, you can treat through, use symptomatic things like antihistamines, skincare, lotions, emollients, topical steroids, all of that. So, what do we do for these bad or not bad type 4 hypersensitivity reactions? Well, there is some literature to say that occasionally delayed skin testing can be useful, or patch testing. I will tell you, I don't know anyone in Omaha that does patch testing to this. And there's some that we really shouldn't even do. But as I said, for the just typical macular papular, we can use skin testing for that, and we can treat through if we need. So why do we care about antibiotic allergy? Well, we want to know, is it truly a hypersensitivity versus intolerance versus another reason that they shouldn't take the drug? Other drugs cost more and aren't usually the best drug to fight the infection. And those other drugs come with their own adverse drug reactions and may actually be at a higher risk of developing IgE immune reactions too. And then a lot of times we need to help our team figure out which drug of the 3 antibiotics were they on in the inpatient setting that led to the reaction, and then obviously to clean up the allergy list and improve patient care. And this is interesting. So 2 studies looked at this in the United States, and less than 1% or 11%, depending on which study, actually had the correct reported drug allergy. So less than 90% of the time. So 90% of the time it's not even correct in the EMR. So antimicrobial, I don't have to tell you guys this is why you're here. The stewardship is a big deal, and I'm going to briefly touch on the 2019 resistant threat report that basically says we need to focus on this because there's almost 3 million of infections that are related to antimicrobial resistance that lead to almost 36,000 deaths, and if you add C. diff in there, it gets even higher. So why is that? Well, evidence-based drug is the often choice of that is Beta-lactam, but unfortunately, our general population has penicillin allergy listed on their chart 10% of the time. Specific populations, such as an 80-year-old white female, it can be up to 30% of the time. So we're going to talk about penicillin allergy now. So we were talking about like drug reactions, the immune system mediated with that. Now we're going to talk about specific drug allergy. So penicillin allergy, I already told you 10% of the general population have it on their chart, but over 90% of them can tolerate. And this figure shows you, I love the figure, it's 100 patients, and 10 of those are yellow that have an allergy, and that only one little red person is truly allergic. Skin testing is validated and established, and the negative predictive value is over 95%, which is good. And the majority of penicillin reactions, specifically to penicillin, the drug, not aminopenicillins, are due to beta-lactam ring, although you can be allergic to the side chain. And incidence is decreasing over time, probably because we're better at making drugs, but also we're just not using penicillin that much. So this study was published in 2014 out of California, where they at Kaiser, where they have access to multiple one EMR that connects multiple hospitals together, and they did a retrospective match cohort study. So they looked at 52,000 patients, so that was the sample, and compared them to another 52,000. So this is like 100,000 patients were reviewed. And they looked at patients with penicillin allergy and compared them to their cohorts that do not have penicillin allergy. And as you can see, the patients who have penicillin allergy on their chart did not do as well as their matched cohort. And these patients were matched by age, underlying illness, reason for hospitalization, and acuity in the hospital, so ICU versus floor, etc. And as you can see, they stay in the hospital longer, they have a lot more C. diff, MRSA, and VRE, nothing that we want. Okay. They also looked at what drugs these patients got, and as you can see, the cases had vancomycin over 20% compared to 12% in the control subjects, and cefazolin was used a lot more in our control subjects, and we all know that's a better drug for a lot of things. And then there's been a lot of studies that have looked at Does it cost more? And it does. Basically, just having penicillin allergy in your chart costs the healthcare system a lot more money. Okay, so who should be tested for penicillin allergy? Honestly, anyone. And we'll talk a little bit about that. We may not have to skin test anymore, and we may be able to go to direct challenge. But you really want to look at people who have underlying illnesses that lead to needing more antibiotics. Example would be a cystic fibrosis patient, frequent infections, or likely to have infections, so a neutropenic cancer patient, planned surgery, expecting mothers for GBS, and obviously immunosuppressed patients. And when it comes to surgery, orthopedists are actually very good at sending patients to us so that they can get penicillin allergy off their chart and get the best drug to protect the patient from infections of total joints. So penicillin skin testing. So I told you this is the only validated skin test, and it's because we know what is the antigen. So penicillin is right there in the top left. That drug is actually not antigenic. It's the metabolites that are antigenic, and the first is the major determinant, which is 80% of what the penicillin is metabolized down to, but it's because it binds to the protein, and that's what makes it antigenic. We can purchase this from the market, and it's pre-pen, it's in our clinic. And then we have minor determinants, including what's penicillin G, like you'd give IV, as well as these minor mixtures. The reason why I have minor mixtures highlighted is ideally we can skin test to this, thanks to things that I don't want to talk about that anger me. I can't skin test to this anymore at UNMC, but before I could skin test and just remove the penicillin allergy if it was negative. Now I'm not allowed to make it for federal regulations, even though it's not therapeutic. So I already told you drug allergy skin test is a two-phase with the prick and intradermal. Takes about an hour all said and done between the initial consultation and the skin test results, which are read 15 minutes apart, so 30 minutes total. And then skin test outcomes. So without all the minor determinants, as I told you, I can't test it with the mixture anymore. Now I have to do a two-step amoxicillin, and it's because that skin test could miss about 20% of positive skin tests, but the negative predictive value is still actually greater than 95%. If I have all of them, the negative predictive value is 100%, and therefore we could just remove the allergy without even doing a two-step amoxicillin challenge. And really, no matter how we get to the fact that the patient tolerates, the risk of an immediate, remember we're only testing for IgE mediated, is the same as the general population. They still can develop delayed maculopapular rashes up to 10% in pediatric patients, but in short, we remove the penicillin allergy and the EMR is updated. If it's a positive skin test, we review the clinical history, but usually the allergy remains on the EMR, and the EMR is clearly updated to note that this is probably a true allergy and had positive testing. We can always desensitize if we need. Now, fortunately though, depending on what literature, many studies have looked at this, up to 100% of the time the test is negative. So what about going to direct amoxicillin challenge? Like, do we even need to do penicillin testing? Well, this study was published in 2020, and it looked at inpatient direct amoxicillin challenge, and they screened almost 400 patients. Now, I will point out their exclusion criteria was very strict. So if the patient had an itchy rash less than 1 year, okay, maybe need more than that. A scar, agree with. Moderate severe IgE symptoms, agree with. Rash that is NOS less than 20 years ago. That 20 years seems a little bit more than needs to be. Probably 10 or even 5 would be okay. But they included a rash NOS that was over 20 years ago, hives, interestingly enough, and unknown reaction over 20 years ago without emergency department treatment, GI symptoms, or family history. I would argue if you have someone with a family history of penicillin allergy, you don't even have to challenge them, you just remove that from the chart. But anyway, they did this with a 3-step oral amoxicillin challenge, and 97.9% tolerated, which was 47 patients. So as you can see, we started with 372, and because of their exclusion and inclusion criteria, they were only able to challenge 47 of those patients. One patient had redness and swelling under the eye. Interestingly enough, if they couldn't do a challenge because of their inclusion and exclusion criteria, they did do penicillin skin testing, and if it was negative, they did a one-dose challenge. 100% of those patients tolerated it. And in the outpatient setting, there have been other studies that have looked at this. This one was just published in 2019, and they looked at doing a direct challenge with 1/10 and full dose, which is what we do after our penicillin skin testing. And they actually divided their patients out based on age, and including pediatric and adult patients. So if the patient was less than 5 years old, they just did a direct challenge, no matter what. They didn't care what the history was. If they were less than 5 years old, they just did a direct challenge, which included 13 patients and 100% tolerated. The reason why they could do that is there's clear literature in the data at this age, or clear literature in this age group, that these patients are receiving amoxicillin, and this is amoxicillin-induced rash with a viral illness, not amoxicillin allergy. For 5 or older, they divided it out based on symptoms. So if they had skin findings only or unknown reaction and they were 5 to 17 and over 1 year ago, or 18 and older and greater than 10 years ago, once in that, and that's looking at what likely the drug was, since we know our history of allergy is not good. You know, if this was 50 years ago, that drug likely was penicillin, versus 5 years ago, that drug was likely amoxicillin. And so they used age to do that. And they did a 1-to-1 randomized study to penicillin skin test versus the 2-step direct challenge. So 80 patients got the penicillin skin test. 70 of them were negative. I will tell you, I rarely get a positive test. So having 10 positive skin tests seems very high to me. And all tolerated the challenge after they were challenged, but the positive test was not challenged, as the negative tests are challenged. And then of the direct challenge, of 79 patients, 76 tolerated, so that was a 96.2% tolerance, and all reactions were minor, very, very minor, like just a little itchy, fleshy, stuff like that. So, and if the patients had any symptoms that were outside of the skin, they underwent penicillin skin testing, once again had a high rate of positivity. So this brings up the question, is our penicillin skin testing overcalling some of this penicillin allergy? And maybe we need to do more direct challenges, and they're probably safe to do if you have a good algorithm in place. So speaking of algorithms, this was published in JAMA in 2020, and this is a penicillin allergy clinical decision rule. So it's a multi-center prospective antibiotic allergy tested cohort of originally 622 patients in Australia. And I have to say in Australia because technically drug allergy outside the United States can be different than drug allergy within the United States. But then later on they did add Nashville, Tennessee as one of the sites. And they found this thing called Penfast. So they basically looked at patients who were sent for evaluation of allergy, and they were trying to figure out, okay, can we come up with a clinical history or questions that makes it likely that their penicillin skin test is going to be positive in our clinic? And they found four features were associated with that. And so they used this term Penfast to get an idea, or for clinical providers to ask it quickly with not having to remember too much. Penicillin allergy. F stands for occurred 5 or fewer years ago. That gets you 2 points. A stands for anaphylaxis or angioedema, also gets you 2 points. S stands for scars, 2 points, because obviously you don't want to do that. And treatment required for an allergic reaction, 1 point, so that's the T. And Penfast less than 3 was determined to be a low risk because 3.7% of those patients had a positive allergy test. And because of all this, with all the statistical things, this Penfast clinical questionnaire has a negative predictive value of 96.3% of having a negative skin test. And just to give you an idea, this is like an example of what you could put in your EMR or in your clinic, just to help you with scoring. And this shows the various sites. So this includes the 2 Australia main ones. Sorry, the first one was the main one, and then the 2 other ones that were added, and the Nashville one. But it shows in general the negative predictive value stays the same, but the Nashville actually was even a little higher than in Australia. All right, so we're gonna now talk about chemistry. So I first gave you immunology, and now I'm gonna give you chemistry, and I apologize. I know that's not always fun, but for pharmacists, they love chemistry. So, Beta-lactam. So, we talked about penicillin allergy, and then there's always this question, well, what about other beta-lactams in penicillin allergic patients? Well, unlike other beta-lactams, penicillins have that ring, which starts with a T, and they do not have an R2 group. Aminopenicillin allergy is rare in the United States per the literature. I will tell you, I see it in my clinic. But in Europe, it's a third of the cause of reactions to penicillin, and of those 35% do cross-react with the cephalosporins with the similar side chains. In general, with literature from 1981 on, the cross-reactivity between penicillin and cephalosporin is 2%. If you have ever heard 10%, that is prior to 81, and that's because our IV cephalosporins had penicillin in them. Beta-lactam cross-reactivity, a little bit more about that. It can be through the core ring, but that's very rare. Usually it's the adjacent rings, and depending on if penicillin or cephalosporin, which ring that is. And actually much more side chain R1 or R2. True cross-reactivity is primarily due to the R1 side chain. R2 can be. But interestingly enough, no matter what the allergy is, whether it's penicillin or cephalosporin, 99% of these patients tolerate carbapenems, even though they are beta-lactams. Remember, amoxicillin equals ampicillin, and we need to avoid certain cephalosporins with similar side chains related to that. And so this is from an article published in Lancet in 2019. I like to highlight this because this is a really, really good figure. Like, you can look at this figure and know anything and everything about beta-lactam cross-reactivity. First off, on the left side is just like the basic structures that points out what is usually related to the allergy reactions, including the core beta-lactam ring. The center is, okay, you can line up where the patient's allergy list is, or allergy is, and what drug you want to go to, and assess the risk of having cross-reactivity. So penicillin to cephalosporin or back, 2%. Cephalosporin or penicillin to carbapenem or back is less than 1%. And monobactam, H3N is technically a bit in here because it is a monobactam. There's no cross-reactivity. And then what's really helpful is this third column right here that is really assessing the side chains and their similarity, and so the likelihood of having cross-reactivity. And as you can see, that second box, the shared side chains for penicillins and cephalosporins of R1, that's the amoxicillin with the cephalosporins you cannot use, and the ampicillin with the cephalosporins that you cannot use. I also want to point out on this, the very bottom one is cefazolin. As you can see, it doesn't cross-react with anything, and it's because if I pulled up that structure for you, it is very, very different than any of the other beta-lactams, and that will come to be more important in a couple slides when we talk about perioperative antibiotics. So beta-lactam challenges, we do have them at University of Nebraska Medical Center. This is the website to where you can find that, and this is all the allergy guidance that we have, including desensitizations, cross-reaction tip sheet, beta-lactam graded challenge order set, so you can pull them into your healthcare system if you want, and just a penicillin allergy guidance document. I will admit, this is pre-COVID, it needs updated. We've only been doing COVID for the last 2 years. We will start working on it again and give you even more updated guidance soon, I promise. And in this is this figure 1 in the penicillin allergy guidance, so that last link, that can really assess and give you an idea of, can you challenge a penicillin allergic patient to a cephalosporin? And just go to that link, it's there. This slide is way too busy, you're not gonna memorize it. Just know to go to that link and look, and it'll take you right down. And in general, yes, you can do a challenge to cephalosporin, unless it's something that is really recent, IgE mediated, or something in the history that makes you worried. It's one of those big bad boys that we talked about. Okay, so I told you cefazolin doesn't cross-react with anything. Well, this was published in 2020, and it was trying to find a streamlined penicillin allergy evaluation perioperatively, and it was multidisciplinary, meaning, physicians, surgeons, anesthesiologists, pharmacists, all that stuff, to develop an algorithm. And they compared cephalosporin use in the OR before and after, and safety was assessed, which really was a genius. They looked at who received diphenhydramine or epinephrine in the OR, or diphenhydramine within 24 hours post-op. They looked for 3 years. 9.3% of their patients had penicillin allergy, and what they found is once they instituted this algorithm, their cefazolin use went from 22% to 80% in these patients. No epinephrine was ever needed. 1 patient had a delayed rash, but they continued the same cephalosporin. And 3 patients did require diphenhydramine, but it was just itchiness without rash, which I would argue is probably the anesthesia and not the antibiotic. And then this is a figure that just shows all of that and what they were looking at. This is the algorithm that they put in place. Once again, too busy, too much for you guys to know it's there in the literature and to institute it in your institution. And this is an example of a questionnaire you can have your clinicians use that tells you questions to ask to to avoid accidentally giving someone with a severe cutaneous adverse reaction a Beta-lactam that they shouldn't receive. So what about in pregnancy? Well, GBS and cesarean sections are common. Treatment of GBS and cesarean sections are common, obviously, and beta-lactams are the #1 drug for that. And so this study was a retrospective study of allergy referrals from OB, and they had this e-consult, and then they recommended in-person evaluation. If they did that, they got penicillin skin testing. 399 patients were evaluated via e-consult. Of those, over 90% were recommended for an allergy evaluation, but only 222 actually showed up for that. And of those, 99% were skin tested. And as you can see, for the majority of the time, they actually removed the penicillin allergy. 1% had a positive skin test and 1% had a positive challenge. Compared to patients that did not have in-person evaluation, so basically the patient didn't do what the OB recommended, they reduced the vancomycin, clindamycin, and gentamicin use. They increased penicillin use. It was safe, not just for the drug use, but also for other OB outcomes like term delivery, C-section, all that stuff, and only treatment required, which was very rare, was antihistamines. And this is a figure from that shows basically what I told you, that penicillins were used significantly more, which is the blue bar there, if they had their allergy evaluation compared to someone who didn't. So what about cephalosporin allergy? Well, IgE-mediated reactions are even more rare than penicillin, and you resolve that allergy quicker than penicillin, and it's to the R group like we talked about. And there's no validated skin testing available, but we can skin test at UNMC for this. This is that chart that I was talking about that showed those cross-reactivities. So what happens literally is I see a patient in clinic, I assess what drugs they reacted to, I skin test them to the form, and if they are or to the panel, if they are negative, I challenge them to a cephalosporin that's in a different group. You can also use this when you're considering doing a cephalosporin challenge to someone with a cephalosporin allergy. Pick a cephalosporin with a different R group, put them in a safe place, like an infusion center or in the hospital, and challenge. And cefazolin, once again, not going to cross-react. So other antibiotics, carbapenem, we already talked about it. It doesn't cross-react. What about clavulanic acid? So I want to bring this up. So we have patients who have amoxicillin allergy listed on their chart. It's actually not amoxicillin, it's augmentin. And IgE-mediated to clavulanic acid does exist. We have to skin test them to augmentin. Unfortunately, in the US, I can't skin test them just to this agent like in Europe. But those patients can still receive amoxicillin. They just can't have augmentin. Sulfa. The thing I want you guys to know about sulfa allergy, #1, it doesn't lead to IgE-mediated reactions. For learners, if you're tested on anything and you don't know the answer and it's drug allergy, pick this because it's the one that does all the bad stuff. And then we can challenge these patients. So high-risk patients such as HIV have up to a 50% risk of having true sensitivity, but when we challenge them in the future, 73% tolerate the challenge on repeat challenge. So someone who is a transplant patient who needs Bactrim for PCP prophylaxis, they should be on Bactrim. Get them to us, we will challenge them, and even if we can't challenge them, we can desensitize them and get you the best drug for the prophylaxis. Vancomycin, red man syndrome, red man syndrome, red man syndrome, not an allergy. This should never show up on an allergy list unless it's something of the big bad boys like DRESS or vasculitis. And because of this, we can't skin test, and these pictures are to show that red man syndrome looks like IgE-mediated. It can even drop your blood pressure like anaphylaxis. Fluoroquinolones, we use these because of penicillin allergy. They actually have higher rates of IgE-mediated reactions than beta-lactams, or second to beta-lactams. And the highest is moxifloxacin. The thought is the whole class cross-reacts, but those are in vitro, not in vivo studies. We can skin test to these in our clinic, and we challenge to one that has a negative skin test. If you have a beta-lactam allergy, actually you're more likely to have a risk factor for developing a hypersensitivity to fluoroquinolones, and those are the patients who are using this. All right. And then what do I do for a patient being evaluated for infection with an antibiotic? You ideally remove it, but really we are trying to do all of this stuff so that we can get them the correct antibiotic. And remember, we can challenge to things that don't cross-react, and we can desensitize to a drug if you need it. And you can consult infectious disease or allergy. And please, please, please go to the Antimicrobial Stewardship website for all the allergy information. So just to summarize, drug allergy sections are usually inaccurate. Most common drug hypersensitive reactions are immediate or delayed, type 4 macular papular rashes, and we can do something with those. Make sure you know what a scar looks like, be able to define it, find it, and not give your patients a drug similar to that if they have that history. Penicillin skin test is our only validated skin test, but we can skin test to other things if we need. Cross-reactivity between penicillin and other beta-lactam antibiotics is rare and really considered challenging. Drug challenge can be utilized, and desensitization is also available when needed. And if you have any questions, I am literally at 11 o'clock, so I don't know if we have any time, but this is my youngest of 3 babies right there thinking about questions.
Thank you, Dr. May, for the talk. Yeah. Question that I have is that what is your strategy that you recommend of someone that has been, tested for allergy, deemed to be, non-allergic, continue in the future, get on the list again? What are the strategies that you recommend that doesn't happen?
Make EPIC better. So what he's referring to is when we test someone to penicillin allergy and we remove that from their chart, we literally remove it from the allergy list. We provide a printed out document for patients to take with them that says clearly what we did and to update any provider outside of our healthcare system, dentists and pharmacists, so that, like their Walgreens or whatever, that they're no longer allergic. But unfortunately, what happens now, that patient goes to CHI and they get admitted and they click, oh yeah, allergy reviewed, and it pulls it back in. And the next time the patient shows up at UNMC, that penicillin allergy is back and nothing happened. And there is not a way to fix that. That is truly an EPIC problem, and so you have to educate your patients about that. Now, that being said, what should happen in EPIC is it should pull up the most updated information, and we do list in the penicillin allergy negative skin test, past amoxicillin challenge, allergy, and the date of the encounter, so that someone could, in theory, go back and look at that. But that is a risk factor, unfortunately, for EPIC. There are a lot of things related to allergy section in EPIC that needs fixed.
And I think it probably also interferes with the dynamic also, because there are nursing homes that may not have the same systems and things like that, and if their record might still show, and there may be paper records also.
Yeah.
So that can also probably play a role there too.
Yes. So yes, he brought up a good point. So patients in long care facilities, they come with their paper chart or information, and then anyone in the system can add it. And so if penicillin allergy is still on that chart, it will get added back in.
Thank you for a great presentation. Can we have an updated copy of your slides? That's one. Number two. So if you have a patient with scar, so like agent, and you don't have too much option regarding agents, let's say the patient has Pseudomonas infection, and you cannot use quinolones, you cannot use aminoglycosides, and everything else is a beta-lactam. What do you do?
So at that point, you have a physician or clinical provider and patient conversation, and you do education and talk about risk. So obviously, if the patient needs that antibiotic to treat an infection, they need the antibiotic, and not treating the infection has its own risk. For severe cutaneous adverse reactions, we can do delayed reading, I already said that, but most people don't have that. So what you really need to do is have a conversation with your patient and say, okay, the literature is not known. We assume it's actually drug specific, but since these reactions are severe, recommendations or standard of care is avoid the class. I don't have that option with you, so I am going to try to give you another drug in that class and see if you tolerate it, knowing you may react, okay? Now, AGAP's a little different because it doesn't lead to fatality, unlike Stevens-Johnson or something like that. But in general, what I would recommend is you can still use a beta-lactam, but really look at the R1 side chain if you can. Now, the literature is for IgE mediated, but in theory, it's probably also T-cell mediated or whatever for AGAP neutrophil. And try to avoid that, and ideally even avoid, go to a different beta-lactam versus penicillin, so go to cephalosporin, or if you have cephalosporin, go to a penicillin. And most likely, carbapenems are probably also the safest in that. The literature's just not there.